Great, thank you. Thanks for the invitation to come and speak before this group. A cardiac electrophysiologist, it's probably not something that you run into very often in your line of work. You probably deal with my partners more often, the interventional cardiologists, I call them plumbers. I do the arrhythmia work, and so I tell patients I'm the electrician in the group, and then they know why they're seeing a different cardiologist than they typically do. And oftentimes a patient that gets sent to me for syncope has an arrhythmia basis for their problem. And I'm going to talk about syncope as a general topic and then how to identify patients who are most likely to have a cardiac cause of their syncope. First thing is, what is syncope? Syncope is a transient loss of consciousness leading to loss of postural tone. So the patients that you get called to see who are dizzy or lightheaded or they're sitting there nodding off in the back of the room, that's not syncope. Syncope is like this royal guard who's been standing in the sun too long with a wool uniform and a bearskin hat and finally hits the deck. The type of complaints that the patients you're called to evaluate, they're not going to say, neither the witnesses or the person calling 911 are going to say, well, we have a patient with syncope here. That's somebody who fainted, fell out. My personal favorite is I done fell out. They fell down. Particularly older patients, that's what they're going to say, well, it was just a fall. The way you discriminate between a simple fall and syncope is lack of recall. The patient awoke on the floor, doesn't know how they got there. It can be hard to sort out in somebody who's been on the floor for hours. They fell and can't get up. But it's repeated episodes where they don't recall exactly what happened. That was more likely syncope than a simple fall. That also assumes no concussion during the episode. They'll say they blacked out or passed out. I've had patients who really don't want to work up at all and say, no, I didn't pass out and fall to the floor. I just fell asleep and slipped out of my chair. Witnesses will say, well, we were in the restaurant and this person collapsed and they're unconscious, and they're calling 911 for that reason. The reason that's important is syncope, the only differentiator between syncope and sudden death is that with the former, the patients woke up. It can be a serious warning sign for people who are at high risk of death in the near future. So why would I select this topic? Syncope is an extremely common cause for calls to first responders. Up to 50% of patients at some point in their lifetime will have passed out. There are 500,000 new first episodes of syncope per year. It's a huge medical problem, leading to up to 5% of emergency room visits. That's a lot of calls to EMS. It ends up being approximately 6% of hospital admissions, and it becomes extremely common in the elderly. This slide shows the mortality risk of some categories of syncope. A study from years ago that looked at for this laser pointer only shows in the center screen. For people looking on the far side, it's a mortality curve. What happens to a series of patients who've had syncope compared to patients who don't? The top two curves, the dark green curve along the top, the dark green curve along the top is people who've never had an episode of syncope. They die as time goes by, and by 15 years in this collection of patients, about 40% of those people had died. People who passed out from just vasovagal syncope or simple faints have the same mortality risk as anybody else. But the curve in red, right here, are the people who have syncope from a cardiac cause, and their mortality risk is considerably higher. At the 5-year mark, approximately 50% of those people are dead. So when you're called to evaluate somebody with syncope and they're trying to say, no, 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 I don't have to go to the hospital, trying to differentiate, is this likely a cardiac cause of syncope or is this a simple faint, is kind of an important discrimination to make. My hope is to help you figure out which one they fall into. This slide shows a pie chart of what are the most common causes of syncope, and this is after considerable workup. About a third of the time, we never find out why somebody had syncope. They go through all the cardiac and the neurologic testing. They had one episode, and you never figure it out. It doesn't fit into any neat category. But a large portion, this kind of maroon-shaped pie piece between 6 and 9 o'clock, those are the people with vasovagal or neurally mediated syncope. Other than the unknown category, that's the most common cause of loss of consciousness. True orthostatic hypotension is about 10%. Medication-induced is another 7%. Cardiac causes, given its high mortality, is fortunately about 1 in 10 patients with syncope that you may get called for. The other important part of this is to notice that stroke or TIA is an extremely uncommon cause of syncope. And the reason that is syncope is global brain dysfunction. There are patients fine 1 minute, and then down on the floor they go, and then they wake up and they have a non-focal neuro exam. It's extremely uncommon for a primary neurologic problem to cause that. They either have focal neurologic symptoms before, or they wake up with focal neurologic symptoms afterwards. So I'm going to spend a fair amount of time talking about neurocardiogenic syncope, because that's the most common cause that you'll see that can be identified. And then the highest risk group is the cardiac causes of syncope. There's a mnemonic with just walking in at the end of one of these lectures and seeing all the information you're getting barraged with. I'll be impressed if any of you ever memorize this mnemonic, but it's a nice way to summarize some of the most common causes of syncope that you'll be called to evaluate on the scene. Some of the most straightforward ones with your initial assessment, you take a brief focused history and then the physical exam. If they're hypotensive from volume loss, that'll be apparent pretty quickly. Arrhythmias, it'll be apparent if you hook either by feeling their pulse or you hook them up to a monitor if they're having arrhythmia at the time that you arrive. Typically what happens is the patient passes out, squad gets called, and by the time you arrive, the patient's awake and there's no particular abnormality in their vital signs or on their monitor. And that can be a diagnostic challenge, but that's what keeps me employed, thankfully. Seizures are actually a relatively uncommon cause of syncope. Remember, I'm saying defining syncope as abrupt loss of consciousness with loss of postural tone. Hypo or hypoglycemia, you'll find out pretty quickly if the fingers stick. Low output because of cardiac causes. These are primarily obstructive cardiac lesions like critical aortic stenosis or mitral stenosis. Hypoxia from a massive PE, relatively uncommon causes in the big scheme of things. We'll go through a list of some other zebras. And as I had said before, neurologic causes of syncope are relatively infrequent. The low output, so we said, okay, hypotension and arrhythmia, those are relatively straightforward from your initial evaluation. There's the high or low blood sugar, you got a quick finger stick. The kinds of things that, the structural heart disease that can lead to syncope is critical aortic stenosis or mitral stenosis, or the obstructive form of hypertrophic cardiomyopathy. You'll hear those, you may hear those with a murmur. Depends on the environment you're in and how noisy it is. You may hear the murmur of aortic stenosis or find a weak carotid pulse from critical AS. In 20 plus years of doing this, I've only seen one patient with an atrial myxoma large enough to occlude the mitral valve and cause syncope. Similarly, tamponade causing hypotension is more an acute problem related to a hospital adventure and not likely something that you're going to see in the field as a cause of syncope. For pulmonary causes, there would have to be a large, massive PE to cause syncope. They're probably going to present with dyspnea or chest pain before they present with syncope. End-stage pulmonary hypertension can, carbon monoxide poisoning. Psychiatric causes, at least I'll admit to some selection bias. It may be obvious to the people who initially evaluate the patient that there's a psychiatric issue going on here, so that they don't get referred to me, they get treated for their psychiatric issue. And I'm grateful for that, but so it's not, by the time I see the patients or by the time they get into the hospital series for what causes syncope, these are relatively uncommon. The types of CNS event that can cause syncope would be large subarachnoid hemorrhage, or from my perspective, a fascinating syndrome, basilar migraine headache, that it's one of those zebra things that you won't be diagnosing in the field. So other than the unknown causes, which is about a third of the patient population, the most common cause of syncope in most series, and the kind that I expect that you'd be most likely to encounter in the field, it goes under a broad category of neurally mediated syncope. The most common form of that, there are, believe it or not, different forms of neurally mediated syncope. There's vasovagal syncope, which is kind of a common faint. You have the good fortune of working a Justin Bieber concert and somebody swoons for the Bieber. That's probably vasovagal syncope. I'm assuming a young teenager with no other medical problems. It's that form, and the kind that many people, I suspect, in the room have experienced at some point or other in their life, where there's an acute either heat stress or volume depletion, or in the case, I guess, of Justin Bieber, emotional stress can cause you to faint. And a variant of that is carotid sinus hypersensitivity, and then situational syncope. This group of patients, they're all manifestations of an abnormal baroreceptor reflex, fortunately have an excellent prognosis. That assumes that you can control their syncope so that they're not cracking their head, falling in the bathroom from syncope, or they're not behind the wheel causing motor vehicle accidents. The syncope itself doesn't cause the injury, it's what occurs to them after they've lost consciousness. So vasovagal syncope, the kind that people get when there's drawing blood, in this case the guy, it appears to me that they're drawing blood outside of the betadine prepped area. So I'd be pretty upset too. But trauma, pain from medical procedures, for some people with a delicate constitution, just the sight of blood will do it. Heat exposure, diarrhea, medications, diuretics can all cause volume loss. And under the right situation, those patients will pass out. Classically, when you arrive on scene and the patient's already woken up, and they'll give the history, well, you know, I was sitting at dinner and I had a drink and I just started to really feel warm. I didn't want to make a fuss, so I tried to make it to the restaurant bathroom, and I started getting sick to my stomach, and then down I went. Then, as soon as they're on the floor, 30 seconds later, they wake up, they're sweaty all over, they feel crummy still, but otherwise they're okay. And in the current legal environment, the restaurant's called the squad. No matter what happens, they're calling the squad. And you get there, and the patient will give this story where there's a prodrome. Most commonly, the prodrome includes a sense of increased warmth and then the diaphoresis and some GI symptoms. Some patients have even described to me they feel like they have to go to the bathroom. Lasts for variable periods of time. The longer, the better in terms of the treatment. Then there's a variable period of loss of consciousness, and it's not that they just sat in the chair and heard things went black, but I heard everything that was going on around me. That's not syncope. They lose consciousness. And then the post-syncopal phase, where curiously one of the things that's most common is that the patient will feel extremely fatigued for hours or sometimes days after the episode. These patients, they have an excellent prognosis. They have no other medical problems generally. And the management is usually just tell them, when you feel this coming on, lay down. Or if it's triggered by heat, hot environment, avoid a hot environment. Or hydrate better, have more salt. Usually it's a behavioral thing. For patients who keep having episodes in spite of that, then they're, oddly enough, it's treated with beta blockers, which seems crazy. You have somebody who's fainting from low blood pressure triggered by an abnormal baroreceptor reflex, and you're going to treat them with beta blocker. Seems crazy, but it works. And curiously, so does Zoloft. The serotonin reuptake inhibitors, they work in one part of the brain because of the role of serotonin in management or in regulation of emotions. But the serotonin's used in a different part of the brain for regulation of blood pressure. So if the patient continues to have syncope and you're called to the scene and they say, well, I'm on Zoloft because I keep passing out, it's not because we think they're crazy generally. It's because it can actually be helpful in that syndrome. Nowadays, pacing, this abnormal vasovagal response is primarily vasodilation and hypotension. Typically, there's some slowing of heart rate. In some patients, there can be a very dramatic bradycardia, but the treatment is avoid the hypotension in the first place. Pacemakers really have almost no role in this syndrome anymore. So we talked about the different forms of neurally mediated syncope, most common being vasovagal. Another is carotid sinus hypersensitivity. The history that you get on the scene is, and typically it's hard to tease out because a patient won't have had this a whole bunch of times, is that there's some manipulation of the neck. I don't wear a tie because I just don't find it comfortable. But I had a sheriff's deputy who had repeated episodes of syncope whenever he'd turn his head left before making a right-hand turn. And sure enough, you press on his neck and he'd go asystolic. Thankfully, easily fixed with a pacemaker. That's one of the few neurally mediated syncopes that is benefited by a pacemaker. Relatively uncommon as of the different types of neurally mediated syncope, however. Situational syncope is also not as common, but it's somebody who, the ones I've most commonly seen have been either with swallowing or with coughing. And classically, it'll be a COPD patient who gets into one of their coughing jags, and it just goes on and on and on, and the increased intrathoracic pressure diminishes venous return, and if it's severe enough and long enough, they'll pass out from that. Treatment of that, unfortunately, isn't easy, but it's prevent the cough. Any of the usual cardiac things won't help. If it's an issue with swallowing, well, then treat whatever it is that's causing the patient to have pain with swallowing. All of these neurally mediated causes of syncope are distinct from true orthostatic hypotension. And this is where the initial evaluation in the field can be extremely helpful to the emergency room staff and then the cardiologists if we get involved downstream. Orthostatic hypotension, a significant drop in systolic and diastolic pressure when you go from supine to sitting / standing or any of the stages in between. Easy to diagnose, and technically, a minimum 20 systolic pressure. The problem, or where it can be an issue, is, and the discrimination between true orthostatic and vasovagal is that somebody who's orthostatic is orthostatic all the time, or at least prior to their being hydrated. And what would be helpful is in the field, if it's possible, to do orthostatics before the patient is taken to the emergency room. If they're by the time you get there, they're feeling okay, and their pressure sitting or lying on the floor is normal, I'd suggest considering setting them up or standing them up and see what happens to their blood pressure. If they're hypotensive when you move them into a more upright position, the thing to do is going to be to hydrate them en route. But documenting that ahead of time, prior to anybody administering fluid, can make a huge difference in the subsequent evaluation of that patient. Oftentimes, by the time the patient's in the ER and being evaluated there, they've gotten IV fluids, and you've lost the opportunity to really just pinpoint the diagnosis right from the get-go. Orthostatic hypotension can be an acute issue from volume loss associated with trauma, or somebody with a viral illness and GI blood losses, either vomiting or diarrhea, you name it. It's relatively straightforward. Can be cardiologist-induced by over-aggressive diuresis. And it says neurologic damage there, but there are certain neurologic conditions that are associated with chronic orthostatic hypotension. It doesn't matter how much you hydrate them. As soon as the patient's put in a sitting or standing position, they're orthostatic. The most common ones that you'll encounter are Parkinson's patients and patients with diabetic neuropathy. So you get called to the nursing home to transport somebody who passed out in the nursing home, knowing that they have a history of Parkinson's, and finding that they're orthostatic, it pretty much allows you to hit the diagnosis pretty quick. So out of all the causes of syncope, the neurally mediated ones are the ones with the good prognosis. The cardiac causes of syncope are the ones with the horrible prognosis. So I'll touch base on cardiac syncope. There are two basic types, the arrhythmia-based and the structural causes. In both cases, the thing that's common to both is inadequate cardiac output. I had mentioned earlier the high mortality associated with cardiac syncope. And oftentimes when you arrive at the scene, it is really a critical opportunity, because the witnesses or the family members that are there are not going to be in the emergency room and are not going to be there when I evaluate the patient. So here it's an interesting thing to realize that patients with cardiac causes of syncope oftentimes know they have cardiac disease. Somebody with a previous MI, somebody with a history of heart failure, or somebody who has had some sort of arrhythmia symptom in their life before, they know they have a heart problem. It's unusual for cardiac syncope where the patient or family or the medical system has no documentation that they ever had a cardiac problem before. And probably the most under-recognized cause of cardiac syncope is somebody with a remote history of MI who then passed out. They'll blow it off and they say, I've been seen, I've been checked, everything's been going fine. In fact, the cardiologist and all the other heart types that I used to see said, I don't have to come back anymore. Not the way I practice, but the patient in their own mind thinks they're well, but they do have a history of structural heart disease, in this case, prior MI. That's the kind of history that a family member or a coworker may be able to provide to you that can make a big difference when they roll into the ER. And then writing that onto the EMS record so that it doesn't get forgotten in the turnover of medical care providers as the patient's going through the system. I'd mentioned that neurologic syncope is a rare cause. I want to focus on cardiac causes. The approach to the patient with syncope is primarily driven by the history. And as I alluded to, the opportunity to get a history from bystanders and coworkers and family members, depending on where it is you encounter this patient, can be critical to whether the subsequent medical team goes down a neurologic path or a cardiac path, or obviously the blood sugar guys do the hypoglycemia or diabetes out of control patients. The type of information that would be key to try to glean and collect at the scene include what were the events leading up to the episode, particularly somebody who's just out on the street and the only history is going to be from witnesses who certainly aren't going to follow a stranger to the hospital. Anything that they saw leading up to it or as they assisted the patient to recover prior to your arrival. The kind of historical points that would be useful to ask the witnesses is, was this person, if the patient can't provide you with this history, is this somebody who'd been standing in line at a movie theater for a long time? Was this a coworker who passed out as soon as they got up from sitting in a long conference? Was this somebody who passed out on the treadmill at an exercise facility? Was the environment, and you'll be able to know when you go pick these people up if it's a heat stress. Trauma, certainly there'd be evidence of that. Noticing whether there's evidence of incontinence or vomiting or the tongue biting. That's going to be obvious to everybody down the line, the tongue biting. But curiously, tongue biting and urinary incontinence are two highly predictive historical aspects of syncope that do truly point to seizure as the cause. It has a very low incidence, but when the two of them occur together, it's very likely that the issue is seizure disorder. Asking the witnesses to the event whether the patient had a history of cardiac disease, other family members in particular. Coworkers may or may not know, trying to discern whether the patient has had a history of Parkinson's disease, seizure disorder, or diabetes, or a prior cardiac history. Change in medications, particularly in the elderly, somebody titrated their antihypertensive medication, or the patient just said, I'm on this water pill and my ankles started to swell up and I've got this special event coming up and I want to look good, so I think I'm going to double up or triple up on my diuretics so that I look good for this event. That sort of historical information is important to help figure out what's going on. Also at the scene, if there are family members, you can quickly ask, is there a family history of syncope? Are there other family members who've died suddenly for unexplained reasons? That family history part of it is often not available by the time the patient's at the hospital and suggests things like prolonged QT syndrome, hypertrophic cardiomyopathy, WPW syndrome, and then some real zebras. ARVD stands for arrhythmogenic RV dysplasia, and Brugada syndrome. The physical exam's pretty straightforward for the people here. If there's an obvious hypotension, obvious bradycardia, it's not too hard to figure out. I want to talk briefly about the importance of the EKG and diagnosing causes of syncope. The easy ones are going to be top left, for people who can't see my pointer, profound bradycardia, or the top right, non-sustained VT, in this case non-sustained polymorphic VT. That I think will get your attention real quick when you arrive. Less Apparent, however, would be the delta wave of WPW. That's the bottom left, or the arrows point to this slurring upstroke to the QRS. The patients had syncope, you arrive, you do an EKG, and the patient said, I don't really feel anything right now. They feel fine, and they're saying, I don't want to be transported to the hospital. I don't have insurance, I don't want to go. Well, finding something like this on the EKG might push you to really encourage them to make the trip. And then on the bottom right is long QT, one of the more profoundly used, most dramatic example, a QT interval approaching 650 milliseconds, just a massive QT interval. Next, I want to, in the remaining few minutes, talk about the kind of devices. Syncope patients, there's a group that have one episode of syncope, and that's the end of the story. But there's a large group of people who have a recurrent syncope, and you'll be called to evaluate them, and they'll have some sort of device. They'll either have the top three listed here, a Holter monitor in place, and an external loop recorder, and an implanted loop recorder. For people with real bad or a very high index of suspicion for an arrhythmia cause, then they'll have been sent to me to have an EP study. The Holter monitor, most people I think are familiar with. I'm going to date myself and say that it's about the size of an old cassette player that you'd wear on your hip with a couple of wires going up to the chest. Patients wearing it for 24 to 48 hours continuously. It's rare because people aren't having episodes of syncope every 24 to 48 hours out in the real world. It's rare that you're going to find one of those patients in the field with a Holter monitor on. Certainly, if you did, please bring it with you when you transport them to the hospital. That's where the data is, and if it's not apparent from their EKG whether there was an arrhythmia issue or not, the cassette tape within the Holter is going to be critical. It may prove that it has nothing to do with an arrhythmia. It's not unusual to see somebody complain of syncope and their monitor is completely normal, but at least then you can go in the correct direction. An event recorder is also relatively common. I expect many of you to have encountered this before. Patients carry it around for up to a month at a time. It's similar to a Holter recorder. It's external, some sort of recording device on their waist with wires going to their chest. The difference is it's not, although it's monitoring the heart rhythm all the time, it doesn't make a recording until the patient hits the button. It's very helpful as long as the patient has their episode within the 30-day window that you're monitoring, but it also requires that the patient's awake to hit the button. If they pass out prior to hitting the button, nothing is recorded. Some of the newer event recorders will make a recording one of two ways. Either you program in a set of parameters and say, all right, heart rate less than 40 or heart rate greater than 180, make a recording whether they hit the button or not. Same thing as with the Holter. If you come across a patient with that kind of device on, please transport it with them. Less common, I think it's a relatively new technology, is the implanted loop recorder. It's about the size of a thumb drive, and it's implanted under the skin. The batteries on these things last up to 3 years, and so for somebody who has episodes of syncope that are once a year or so, it's an amazing technology. The patient will have an external activator. This bottom right corner shows sort of an older style, but what we ask them to do is wear it in a necklace or lasso around their neck. So if they start to feel bad, they can hit a button. The external activator then sends a signal to the internal loop recorder to store you can get up to 8 minutes of continuous recording. And it has a closed loop system on it, so you can back backdated, if you will, to have captured the 3 minutes or 5 minutes prior to hitting the button. And then, like the external, you can also program it to make automatic recordings. This is a photograph of a loop recorder being inserted. It gives you the size of it. It's about the size of a computer thumb drive. It's implanted in the left parasternal region, lower than where a pacemaker or a defibrillator would be implanted. There'll just be a small 2 to 4 centimeter incision with a rigid, straight device under the skin. And it's not harmed by CPR. It's not harmed by external defibrillation. So if you come across that in patients, you'll know what you're dealing with. So in summary, I hope to have clarified a clear definition of what is syncope. It's abrupt loss of consciousness associated with loss of postural tone. Talked about the most common causes of syncope, a large portion of them being neurally mediated, and then cardiac causes, particularly arrhythmias or obstructive cardiac lesions. And what data at the scene is important to try to get from witnesses and family members, what things to look on the exam and the EKG. And then also, what are the kinds of devices that you're likely to encounter out in the field? One of the device companies has a website, and at the grant table out there is a bunch of cards, if you're interested to pick up, that has the website address on it. So you can go and get information about defibrillators, pacemakers, loop recorders, and see if it'll answer any questions you may have about encountering those devices when you're seeing patients out in the field. That's it. Thank you for your attention. I have a couple of minutes for questions. The question was, what's the frequency of long QT? And because it appears to be becoming more prevalent, in population studies, the incidence is on the order of 1 in 10,000. It's relatively uncommon, or at least primary genetic long QT. Drug-induced long QT is probably more common, both because of the increased use of antiarrhythmic drugs and the increased recognition that even that non-cardiac medications can cause long QT. Antibiotics, antifungal agents, bizarre things that a cardiologist has no knowledge of. As the FDA has become more and more aware that a wide variety of medications can cause long QT, there's a heightened surveillance of it. So I think it's more heightened awareness of it and additional testing that makes it that we're picking up more of what was out there to begin with. Thanks. Good. Thanks for your attention.